Hi, my name is Adam Levine. I am a professor of emergency medicine and international public affairs at Brown University and associate dean of global health equity at the Brown University Division of Biology and Medicine. And I'll be presenting on diarrheal illness and approach to rehydration and treatment. First, I have a few disclosures. I've received funding for some of the research I'll be presenting from the U.S. National Institutes of Health and the Thrasher Foundation and Rhode Island Foundation. And all images and videos in this presentation have verbal or written consent from the patient or parent of the person in the video or image for inclusion in this presentation. Globally, diarrhea is the second leading cause of illness in the world after upper respiratory infections. There are over 6.5 billion cases of diarrhea each year, which result in about 1.4 million deaths. About a third of those cases are in patients under 5 years of age, and about two-thirds in patients over 5 years of age. Globally, diarrheal disease is the eighth leading cause of death and disability in the world. And in low-income countries, it's the fifth leading cause of death and disability. And in children between the age of 1 month and 5 years, it's actually the second leading cause of death globally. We know that accurate assessment of dehydration and appropriate rehydration are by far the most important components of diarrhea management, as both under and over treatment can have serious consequences. In fact, meta-analyses have found that patients who are treated with IV fluids who do not have severe dehydration and do not need it are at increased risk for complications such as seizures and even death from fluid overload. The World Health Organization defines diarrhea very simply as greater than 3 loose stools in a 24-hour period. And they recommend two different steps in terms of deciding on the management priorities for patients with diarrhea. First, determine the severity of dehydration due to diarrhea, and that's usually divided into 3 categories: none, some, or severe. Other authorities divide some into mild and moderate, but for our purposes, we'll group those together. And the second is to determine the subtype of diarrhea, which is less important, but still can change management in certain settings, particularly if the diarrhea is bloody, or there's concern for cholera, or if the diarrhea is chronic, which means it lasts longer than 7 days. We'll be discussing only acute diarrhea in this presentation, but for diarrhea that's been going on for more than 1 or 2 weeks, there are different management priorities. The World Health Organization Integrated Management of Childhood Illness Guidelines, which are now over 30 years old, are meant for use in patients under 5 years. And they have recommended for many decades assessing dehydration using these 4 signs: lethargy or unconsciousness, sunken eyes, not able to drink or drinking poorly, and skin pinch going back very slowly. They recommend that if a child has more than 2 of these signs, they be classified as severe dehydration. If they have 2 of the following signs, either restless or irritable, sunken eyes, drinks eagerly or thirsty, or skin pinch goes back slowly, then they be classified as having some dehydration. And they have less than 2 of the signs from either of these categories, they should be classified as having no dehydration. Well, these clinical signs and this algorithm has been the mainstay of assessment of dehydration in patients with diarrhea for the past 3 decades. In fact, it was never actually developed based on empiric evidence, but rather based on expert opinion. And no studies were ever done to validate these in a prospective population of patients to determine what their accuracy and reliability actually is for assessing dehydration in patients. The World Health Organization Integrated Management of Adult and Adolescent Illness Guidelines, which were developed somewhat later than IMCI, are intended for use in patients over 5 years, and they essentially recommend the exact same guidelines. Again, not validated in this population prospectively, but rather just based on expert opinion. Since then, in the past decade, newer research has actually developed empirically derived signs and symptoms for assessment of dehydration. In particular, my research team worked on the DACA score, which developed a new scoring system for assessing dehydration in patients under 5 years with acute diarrhea. And this incorporates some of the signs from the WHO algorithm, general appearance, and skin pinch, for instance, but drops thirst and sunken eyes, and instead uses tears and respiration depth. This algorithm was actually developed using machine learning modeling on a prospective population of over 850 children who were enrolled with acute diarrhea and then assessed using the gold standard assessment for dehydration, which was percent weight change with rehydration. And these four signs were found to be the most accurate combination of signs for assessing patients as having severe dehydration, some dehydration, or no dehydration. Patients who have a DACA score of greater than 4 should be treated with severe dehydration, while a score of 2 to 3 should be treated as some dehydration, and a score of 0 to 1 as no dehydration. In the validation study published in the Lancet Global Health, which directly compared the DACA score and the WHO IMCI algorithm, they found that the accuracy for the DACA score was significantly greater than that of the IMCI algorithm. The reliability, which meant when two different clinicians assessed the same patient using the same algorithm, they found the reliability for the DACA score to be greater than that of the IMC algorithm as well. And putting this into practice, universal use of the DACA score could detect an additional almost 500,000 cases of severe dehydration in young children that would currently be missed by the IMCI algorithm, given its greater accuracy. My team also developed a score for patients over 5 years of age, empirically deriving this from a population of over 2,200 patients over 5 years with acute diarrhea who presented again in Bangladesh. And these 5 signs, skin pinch, eye level, respiration depth, urine output, and radial pulse, were found together to be the most accurate and simplest means of assessing dehydration in this population. A score of less than 4 on this Nerudek scale is no dehydration, a score of 4 to 6 is some dehydration, and greater than 6 is severe dehydration. When compared to the Integrated Management of Adult and Adolescent Illness Guidelines, the accuracy of Nerudek was found to be significantly higher, its reliability, again, much higher, and universal use of Nerudek models would detect 171,000 additional patients per year with severe dehydration that the current IMAI guidelines would miss, and also, just as importantly, prevent overtreatment of up to 912 million patients per year without any dehydration, potentially saving healthcare systems a great deal of money in low-resource settings in particular. Both the DACA score and the Nerudek score have been incorporated into a mobile health app, which can be found online at www.fluidcalc.org, and also will be available soon on the Google Play Store, the Apple Store, and in MD Calc. In terms of how you actually assess these signs, this is a video of a child with lethargy, as well as sunken eyes. So this child is not responding to noises or examination and is staring off into space. Absent tears are best evaluated by assessing a child during the exam to see when they start crying and noticing if they have tears forming when they cry. But if the child is lethargic, you can also look in their eye by pulling back the conjunctiva and seeing if the eyes are dry. Deep respirations are evaluated by looking at the depth of breathing, not the rate of breathing. And then this is an example of very slow skin pinch, which is evaluated by pinching the skin of the belly to the right or the left of the umbilicus and seeing how long it takes for the skin to go back. If it goes back immediately, that's normal skin pinch. If it goes back about 1 second, that's slow skin pinch. And if it takes 2 or more seconds, as in this case, that is very slow skin pinch. This is a similar exam in an adult with dehydration. Here you'll be able to see shortly that this adult has very sunken eyes. Apologies. You can also see the deep breathing. This is caused by acidosis that results from the dehydration, reducing perfusion of organs similar to the Kussmaul breathing that occurs in patients with DKA. And then again, here we have skin pinch that is very slow. It takes more than 2 seconds to go back. The reason that we spend all this time assessing dehydration and dividing patients into these categories of none, some, and severe dehydration is that the management is very different in each of these categories. Patients with no dehydration can be treated with expectant management, which means they don't need any real medical treatment at all. Instead, we should encourage the parent to continue breastfeeding if it's an infant and offer extra breast milk. If it's an older child or an adult, we should recommend that they keep eating and offer plenty of extra fluids, though not necessarily ORS. Any fluids will do. And provide the parent or the patient with instructions to return for fever, bloody diarrhea, drinking poorly, chronic diarrhea if the diarrhea lasts for more than 7 to 14 days. Patients, and by the way, that will be the vast majority of patients with acute diarrhea, will have no dehydration and not require any specific treatment at all. Patients who have some dehydration require treatment with oral rehydration solution, either in a health center or clinic or emergency department or some other ambulatory setting. The World Health Organization recommends 75 cc's per kilo of low osmolarity oral rehydration solution be given to the patient slowly over 4 hours under clinical observation, and then the dehydration should be reassessed by the clinician. For patients who have severe malnutrition, Risomol is an alternative rehydration solution that can be used. As you can see from this video, one of the most important things, especially about rehydrating a child with oral rehydration solution, is to make sure that it is given slowly, a few sips every minute or two. If the fluid is given too quickly, the child is very likely to vomit, which will set back the treatment. And perhaps the most common reason for failure of ORS treatment is vomiting that occurs because the fluid's been given too quickly. In some settings where it's available, you can also, if needed, give an antiemetic like ondansetron as well to reduce vomiting and increase the likelihood that oral rehydration will be successful. Very briefly, to take you back to medical school, our enterocytes have sodium-coupled transporters that allow for the uptake of sodium and then passive reabsorption of water, which will follow the sodium. ORS takes advantage specifically of the sodium glucose transporter by mixing equal parts of sodium and glucose molecules in water so that the enterocytes take up both the sodium and glucose, and then the water follows it, increasing absorption so that it's much more likely the patient will get rehydrated than if you just gave them water by itself. Finally, patients with severe dehydration, which will be a minority of patients, less than 2% overall and less than 10% presenting to a health center, will require IV rehydration. And this will typically need to be done in an emergency department or in an inpatient unit at a hospital. The World Health Organization recommends for these patients giving a bolus of 30 cc's per kilo of Ringer's lactate over 30 minutes in patients over 1 year and over 60 minutes in patients under 1 year. And that then needs to be followed by an additional 70 cc's per kilo of Ringer's lactate over 2.5 hours in patients over 1 year and 5 hours in patients under 1 year. Obviously, this treatment requires a great deal of resources, such as a hospital or emergency department bed, trained staff that know how to put in IVs in very small babies, especially IV fluids, IV tubing, and a number of other resources. And so it can be a very expensive option, especially in low resource settings, which is part of the reason why it's so important to adequately assess dehydration and make sure that only patients with severe dehydration are referred for treatment with IV fluids. While assessing and managing dehydration is the most important part of managing acute diarrhea, there are some special considerations that require additional treatment. The vast majority of diarrhea is viral, or even if it is bacterial, does not require antibiotics. However, there are certain types of diarrhea which may require antibiotics or other management options. The first is bloody diarrhea. While there are a wide variety of different causes of bloody diarrhea, including bacterial causes, parasites, and helminths, The one that we worry the most about is shigellosis caused by Shigella dysentery. And that is because it can spread very easily, especially in humanitarian settings or refugee populations or in crowded urban settings. And it can have a high mortality, especially in young children. Shigellosis is one of the few types of diarrhea which absolutely requires treatment with antibiotics. And, it can be noted by looking for evidence of anemia, such as conjunctival pallor or palmar pallor in patients, or obviously by testing a hemoglobin to see if it is low. In addition, if patients have obvious blood in their diarrhea that is witnessed by clinicians, then in those cases as well, they may be treated as having bloody diarrhea with an antibiotic. One thing that's important to note is that most Shigella is resistant to first-generation penicillins and cephalosporins, and so either a third-generation cephalosporin or a fluoroquinolone should be used to treat Shigella in these settings. And the WHO Integrated Management of Childhood Illness Guidelines recommends classifying all children who have bloody diarrhea as having Shigella in settings where you can't do actual diagnostic testing to determine the cause of the diarrhea. And they recommend 5 days of treatment with an oral antibiotic for most patients. Patients who have anemia will likely need to receive an IV antibiotic in the hospital and also be treated for their anemia with a blood transfusion if it is severe. Cholera is the second type of diarrhea that requires special management. This is usually due to outbreaks secondary to a contaminated water supply, also common in refugee and humanitarian settings, but also in many urban slums and endemic in certain parts of the world, especially South Asia. It is the number 3 cause of diarrhea in adults worldwide and kills more than 100,000 adults each year. One of the reasons that cholera is so deadly is because the organism Vibrio cholerae secretes a toxin that attaches to cells, causing them to directly dump chloride ions into their lumen. This causes a secretory diarrhea, which can be much more severe than the usual osmotic diarrhea, which is caused by most organisms, where they damage the villus brush border, and the sloughing of that villus brush border into the lumen of the intestine causes some water to follow it and causes the diarrhea. In cases of cholera, the disease can vary from very mild or asymptomatic to incredibly severe, with more than 10 to 15 liters of fluid loss per day from diarrhea, which can result in rapid transition from a normal healthy patient to one with severe dehydration or even death. The WHO case definition for cholera is severe dehydration or death from watery diarrhea in a patient greater than 5 years. And so when you have a patient over 5 who is presenting with severe dehydration or death, you should suspect that there may be a cholera outbreak in the setting, and appropriate testing should follow. The stool may be rice water in color and consistency, and here's a picture of that type of stool. However, I will caution that rice water coloring is neither sensitive nor specific for cholera, especially if it's only noted by the patient and not by a clinician. And so just be careful in resting your diagnosis on this. Treatment for cholera is appropriate rehydration, as we already discussed, as well as doxycycline 300 milligrams, or for children, azithromycin 20 mg per kg in a single dose. This treatment has not actually been shown to reduce mortality from cholera. Only appropriate treatment with oral rehydration solution or IV fluids has been shown to reduce mortality from cholera, but this treatment does reduce length of diarrhea and reduces the likelihood of patients passing it on to other patients or other people in their population. There is an oral cholera vaccine that has been available for several years, but it requires 2 separate doses 10 days apart and is only 50 to 70% effective, which has limited its use in outbreak situations, especially in humanitarian settings. In situations of cholera outbreaks, it's recommended to open up cholera treatment units separate from a normal hospital, especially in order to keep patients with cholera out of the hospital and stop the spread of cholera, which can be very contagious within a hospital setting. Cholera treatment units should allow for about 50 beds per 10,000 people in the population and be prepared to treat about half the patients in the cholera treatment unit with IV fluids and the other half with oral rehydration solutions. This is a image of a typical cholera treatment unit. Initially, patients come into a triage area where they're assessed for their severity of dehydration. Patients with no dehydration might be sent just quickly to a tent on the right to receive some guidance from a clinician before being discharged. And then patients with some dehydration would be admitted for rehydration with oral rehydration solution, say in the tent on the left, and those with severe dehydration would go into the tent in the middle to be treated with IV fluids. This is an example of a cholera treatment unit with patients receiving IV fluids in cholera cots that are lined up within the unit. And this is an example of a cholera cot, which is specifically designed so that patients don't have to get up and go to the bathroom every few minutes, as they might have to if they're actually secreting 10 to 15 liters of water per day. It has a hole in the middle and then a bucket underneath to capture the fluid and then keep track of how much fluid the patient is losing through diarrhea. So thank you so much. I hope this presentation was helpful, and good luck. Thank you.